Hello, everyone. Thank you for joining the session on indolent lymphomas. We're just going to wait a couple of seconds to let people trickle in. Okay. Hello, everyone. Like I said, thank you, everyone, for joining the session on indolent lymphomas. My name is Gurja, and I'm the Manager of Patient Programs, Research, and Advocacy at Lymphoma Canada. I'm pleased to welcome you today to our speakers, Dr. Skribek, Dr. Gary, and Dr. Stacku, to answer your questions from the indolent lymphomas breakout sessions involving follicular lymphoma, CLL, and marginal zone and Waldenstrom macroglobulinemia. So as a reminder to our audience members, please type your questions into the Q&A box. In the middle of the black, it should be at the bottom of this screen. We will try and answer as many questions as possible within the time limit. I'll direct the questions in a round table format, making sure each presenter has the opportunity to answer questions. If any question comes related to a specific subtype, that Dr. who spoke on the topic in the subtype sessions will speak on it. So everyone can go ahead and put their questions in the Q&A chat. So we do have one question that came along. It's a case-based scenario regarding Waldenstrom macroglobulinemia for Dr. Stacku. So the patient is 83 years old, has heart issues, atrial fibrillation, sometimes high BP, reasonably fit and active. Do you recommend getting the RSV vaccine?
Oh, that's a tough one. Do I recommend it? Yes. I think that older people are particularly at risk, and the fact that we can now have a vaccine against RSV, I think, is a really good idea, particularly with our B cell malignancies, when we know our immunity is already down. The more protected you can be, the better. Interested to see if my colleagues in the panel agree or disagree.
So I think that I would agree with that approach. I don't think there is a recommendation from the National Immunization Committee yet on this vaccine, but there's no harm in proceeding with it. So I think that I would recommend it.
And I would agree, particularly in older patients, that's where it's actually approved. And although, again, the guidance hasn't come out from the National Advisory Committee for Immunizations, but I agree, we are recommending. It's unfortunately not funded in British Columbia. I'm not sure about the other provinces, I assume not. So, it is, I don't think it's mandatory, I think, but if it's available and someone is open to getting it, I do think it's worthwhile to help protect against RSV, which we know can be quite, people can get quite sick from it.
Can the vaccines cause any problems for individuals with indolent Waldenstrom's? WM, I'll just call it, it's a mouthful to say all the time.
Cause any problems? I'm not quite sure what problems you're getting at, but as Dr. Jerry just said, as far as we know, it's safe and it's indicated for older individuals. Not funded yet, as Dr. Jerry said, but I can't see any reason why it wouldn't be safe to get.
How common is it for follicular lymphoma to transform into another subtype?
So over the long term, oh, sorry, is it okay if I answer first? Okay. Over the long term, it's actually fairly common. So a couple of % per year of patient will transform, which with people who live with follicular lymphoma for many years will make that fairly common over time.
Did anybody else want to comment, or next question. Okay, I will move on. Is CAR T therapy readily available for follicular lymphoma?
So Dr. Stacu is shaking her head no. And so, yeah, the answer is not at this time. There has been some review of CAR T for follicular lymphoma nationally, with at least one of the products being provisionally recommended for consideration of funding to the provinces. But that has there is some provision. So, the cost reduction ideally, and each province would then have to come on board with if they're going to proceed with that recommendation or not.
And also, sorry, did you have a comment, Dr. Stacu?
Yeah, I was just gonna ask Pam, is that for the follicular lymphomas with the large cells, or is that all grade follicular lymphomas?
The one CADIT review that was just released was for like follicular lymphoma third line. So even in the absence of transformation, but currently patients who have aggressive lymphoma, so that's a good point, that there would be potential access to CAR T therapy for relapsed aggressive lymphoma when there's an underlying follicular. Sorry, that's what you were meaning, Julie? Okay.
And what exactly does partial remission for follicular lymphoma mean, and is it rare?
I'll let Dr. Jerry, do you want to answer that question?
Sure. So partial remission, basically, it means someone is not in a complete remission, but there's definitely been response to therapy. Because follicular lymphoma is not a curable blood cancer, our goal is not necessarily to completely get rid of everything. We know that there might be a little bit of residual disease and that over time, eventually it will likely grow. But hopefully that time that someone remains in remission is a very long time because we have very good treatments for follicular lymphoma. So I actually don't think it's rare to be in a partial remission at the end of treatment for follicular lymphoma. It's quite common. We don't use necessarily PET scans for follicular lymphoma. I see that was also part of the question about PET scans. And so it's very common to have low level PET uptake after treatment for follicular lymphoma. We don't get too worried about that. We know that this is something that's going to be there. It's kind of a chronic problem, and our goal is not to get every single cell completely gone, but just to really decrease the amount of disease that's in the body. Happy to hear others comment too.
Yeah, I agree. And so it is fairly common, partial remission. And sometimes we can see that reduced further during the maintenance phase of therapy, or it could remain stable for some time.
Yeah, I always tell patients, particularly if you don't always have a PET scan, but you do a CT scan and you see, lots of decrease in volume of the lymph nodes, but not quite gone. A lot of times that's, cells that are just sitting there doing nothing. And so they don't respond to chemotherapy, which only targets those cells that are dividing. So it's not unusual to still see some remnants of lymph nodes and not achieve a complete response that everything's gone. Ideally, we love to see that, but it's not unusual at all to see some remaining pieces of lymph nodes there.
Next question, we have it. How is cancer in the bone marrow monitored?
That's a really good question. We obviously don't want to do bone marrow biopsies over and over again for people. So we have to use kind of clues about bone marrow involvement. And some of those clues, one of the main ones is really what the CBC, what your blood count show you. So what your blood cells are doing, hemoglobin, white blood cells, and platelets. And if those start to go low, that can be indication of disease in a bone marrow. Or sometimes if the cancer cells are very high, that can be like white blood cells, for example, that can be an indication of disease in the bone marrow. Sometimes with more aggressive lymphomas, we can use PET scans, but to give us a clue of bone marrow involvement, but we don't really use that in the low grade or indolent lymphomas.
I think from a Waldenstrom's perspective as well, the cells in the bone marrow produce that particular protein in the blood, that IgM. And so oftentimes in the blood, we'll measure IgM values, and we like to see that it's coming down with treatment as a kind of a surrogate marker as to what's happening in the bone marrow, because presumably if your IgM level is coming down in the blood, then the number of cells that are producing the IgM in the bone marrow are also decreasing. So that's another way that we could tell for Waldenstrom's without actually having to go and look in the bone marrow directly.
Okay, and why is it that CAR-T is not available in many places, and are you hopeful that it will soon become available?
I'll take a first step. I think that, yes, we hope that there's a lot more places that will do CAR-T, setting up CAR-T and the infrastructure to be able to do CAR-T, which not only includes the hospital pieces, so the admission and making sure the other services in the hospital that a patient might require, neurology, infectious diseases, respirology, and even the intensive care unit, that everybody's on the same page. But also the CAR-T, getting those cells and being able to send them to the manufacturing plant, getting them back. There's a lot of regulations and standard operating procedures that a place has to go through. And so oftentimes places that already do allogeneic stem cell transplants, so when you get cells from a different donor, are often well set up to be able to start doing a CAR-T program. But some of the other centers, it becomes a bit more difficult because you got to start from scratch with a lot of those regulatory procedures. So hopefully it becomes easier to do at different places, but it requires a lot of infrastructure and a lot of time and effort by the people on the ground to make it happen.
Yes, I think we could all agree to that. And next question we have is, what triggers a change from indolent to aggressive for WM?
I think, truthfully, it's the same thing that would trigger indolent follicular or another indolent disease to a more aggressive disease. So oftentimes we look at an indicator in the bloods called LDH, and if we see that it's going high, a rapid increase in the volume of lymph nodes or in the white blood cell count, some cytopenias, and truthfully, I think patients who have a transformation to a more aggressive lymphoma generally feel crappy. They come in with more constitutional symptoms. They might be losing weight, night sweats, and fevers kind of at a peaking. So those are some of the signs, I think, for all kind of indolent lymphomas that might be transforming. I don't know, Pam and Aline, if you've got other clues.
Yeah, I don't have anything to add. That sort of outlines well when I would suspect it. And I think that it's a bit unclear why it happens in some people and not others, but it's likely has to do with the genetics of the lymphoma itself and sort of instability with, extra mutations and stuff like that occurring that makes it change.
And next we have, can you please speak about treating younger adults age 25 to 35 who have follicular lymphoma? Is this extremely rare, and what do treatment outcomes look like for this age group?
So that's a very good question. It's not very common, but definitely does happen. And I don't think we have a lot of data to inform us, but there is at least one a study where that's actually out of Ontario. They looked at their patients that were under age 40 and actually found that they generally did fairly well, meaning that they, in some cancers, younger people tend to relapse earlier, have a worse course, and they did not find that in follicular lymphoma. And so, but I don't think we know a lot about it. I don't know if maybe Dr. Sacchio or Jerry know more.
Okay. And the next question is, what are some factors that increase my risk for peripheral neuropathy? Neuropathy, sorry, I think I mispronounced that.
That's an excellent question. So the most common things that we would see that increase people's risk are other diseases that cause peripheral neuropathy. So for example, diabetes. Also, sometimes people already have some entrapment of their carpal nerve from like work, and that tends to be a bit of a predisposition as well to peripheral neuropathy in the hands. Previous toxins like previous chemotherapy would be another risk factor for peripheral neuropathy.
Yeah, I think, and aside from those kind of smaller, like that's not that common. We unfortunately really don't know why some people get neuropathy and some people don't with treatment. So it's just something we need to monitor closely and usually have to adjust treatment if it is developing. Or if people are getting it from their primary disease, which sometimes you can, depending. Same thing, we don't really know why some people get it and some don't, unfortunately.
Okay, and the next question, this patient has CLL and is asking, why was my treatment option only watch and wait rather than chemotherapy like a lot of other lymphoma patients?
Great question. And I did try to go over that in my talk on CLL, really talking about the importance of what we call sort of active surveillance or watch and wait. And it really comes down to the fact that CLL, like the other indolent lymphomas, is not a curable cancer. And so our goals are not necessarily to get rid of it right away, but rather to learn how to live with and manage this cancer for an entire lifetime. And we know from a number of studies that treating early doesn't really seem to change how long people live, basically, and it instead adds added side effects and toxicities. So there's been a lot of studies looking at this, and even with the newer drugs, there are studies reevaluating this. But as it stands now, international guidelines, including within Canada, are that when someone is first diagnosed, if they're otherwise well and not having a lot of symptoms from their CLL, that we would observe for a period of time. And then as we monitor, I talked about in my presentation that that's a really great time to kind of optimize everything else about one's health, diet, exercise, immunizations, all of these things, because we do know eventually things will progress, and at a certain point, many people will require treatment at that time.
Okay, and next question is, are there any statistics that show the likelihood of getting a relapse after 10 years of remission? That's a general question, and you guys can take that.
So I think that's a good question, but it's hard to answer that without knowing more details, because it'll depend on what kind of treatment was initially given, what kind of lymphoma, and so it's hard to answer, to be honest.
I would just say that I agree with Dr. Skrabak. It's a hard question to answer, but going 10 years, presumably from needing treatment to, being well and free of disease, or at least symptoms, is a really good prognostic sign. I think that whether the statistics would bear into that, I think the longer that you can go, and the better disease biology that you likely have, and that means really good outcomes in the long run, I believe.
Okay. And another patient said that they have CLL and have been experiencing a lot of fatigue as a result of treatment. How can I manage this?
Yeah, great question. I wish we had better answers for fatigue. Fatigue is such a hard thing for all areas of medicine, and in particular for, I think, these kind of chronic indolent lymphomas and the treatments that we use for them. So sometimes, depending how severe the fatigue can be, we do adjust treatment. But apart from that, I mean, again, it really comes down to, it's really trying to manage anything else that might be contributing to the fatigue. And kind of optimizing health, certain, making sure people are eating a healthy diet, getting good sleep. Mental health is really important, getting the supports that one needs. Exercise, we know, is a huge, can have tremendous benefit for people in terms of overall well-being and fatigue. Although it seems almost counterintuitive when you're tired to try to exercise, but we know that in the long run that can really help. And then sometimes certain drugs can actually cause other things that lead to fatigue. So sometimes we check things like thyroid levels, iron deficiencies. We want to look for other reasons of fatigue as well. But yeah, that's a really challenging one. And it's important to talk with your healthcare providers, both family physician and oncologist, hematologist, to really think about, is there what else might be contributing to this fatigue that you can optimize or try to help. I don't know if anyone else has other thoughts on that one.
Yeah, I know that the Canadian Partnership Against Cancer worked with at least the Western Canadian cancer agencies to put together some video resources for patients, along with a booklet. And I think those are available through our respective cancer agencies. I know at least from Manitoba West into BC, I'm not sure what happened into the East, but those are available and great resources for patients.
Okay. And are there some predisposing factors that put me at a higher risk for Richter's transformation?
Also, great question. And similar to the question before about, what causes transformation or who has transformation, I wish we knew. And there's a lot of research going on right now to try to figure this out. This is really an area of major interest for researchers around the world. Because, I think this is one area that has not had as much investigation yet, because we've been really focusing on the primary disease, but now we're doing a lot better with all of our new treatments, particularly for CLL. Well, actually all the indolent lymphomas, there's just so many more options, and the focus is now shift partly. There's a kind of interest in trying to figure that out for Richter's transformation, but at this point we really don't know. There's some studies that have tried to that have looked at people with certain gene mutations, and maybe some of them have a slightly increased risk of Richter's transformations. For example, Notch1 is a mutation that was sometimes found in some studies, but it's certainly not a slam dunk. It's not something we routinely test for. Even if someone had it, there's nothing we would know to do to prevent it from happening. Yeah, it's definitely an active area of research and interest for the community, the international community.
Okay, and is hyperviscosity a permanent condition for WM patients?
The hyperviscosity piece itself shouldn't be a permanent condition when you're able to remove the amount of IgM, either by plasmapheresis, so physically removing it out like dialysis almost, or through treatment by decreasing those bad cells in the bone marrow, and then you decrease the IgM. I think sometimes the lasting symptoms caused by the peripheral neuropathy or by the hyperviscosity, if we can't turn them around in time, can be enduring. And so hopefully we catch things before they get too bad. But if you impair oxygen to some of the vital places in the body because your blood is really clogged up and can't move around, sometimes you can get a stroke or vision problems in the eyes, and sometimes those things can't turn around despite us removing that IgM protein. Sometimes the lack of oxygen to those parts of the brain or vital organs is permanent.
Yeah, and we have another question related to WM. So in your opinion, are PET scans helpful at specific points in WM treatment? For example, a diagnosis, after first-line treatment, or upon return of symptoms?
And certainly Dr. Jerry and Scrape pipe in here. I think that as much information that we can get in terms of activity of a malignancy, if that's in lymph nodes and at baseline, the amount of uptake in the PET scan compared to interim scans or later scans or relapse, I think that we all like to have that kind of information. For Waldenstrom's, particularly if there isn't any lymph nodes and you're left either with a big spleen or just the bone marrow involvement and just the IgM, I'm not so sure that a baseline PET scan provides any more information than your initial staging CT scan to make sure there isn't any other lymph nodes, and then following the blood parameters. PET scans aren't ubiquitously available to all patients, which makes kind of prioritizing using a PET scan important for lymphoma. And I wouldn't say that getting a PET scan specifically for Waldenstrom's is high up there on my list of importance, because I think we can use CT scans to assess volume of lymph nodes. And we have other great parameters such as that IgM value in the blood to help us determine what's happening with the amount of disease in the body, particularly the bone marrow.
Okay. And for follicular lymphoma, when treatment is bendamustine rituximab followed by maintenance rituximab, is the end of initial treatment considered the end of BR or the end of maintenance R?
The end of the BR.
Okay. And in your talk, Dr. Stacku, you mentioned that there's no current standard treatment for marginal zone lymphoma. So how do you decide what is the best option for patients? And do you recommend seeking a second opinion in this case?
I think the reason why there isn't a set standard is because marginal zone lymphoma, as I mentioned in the talk, is actually a composite of a few different types of lymphomas. And so, the nodal marginal zone lymphoma we would treat differently. And there is, chemoimmunotherapy, bendamustine and rituximab. If you have some of the extranodal marginal zone lymphomas, like the gastric, the stomach one that I mentioned, treating the bacteria that sometimes causes the lymphoma is a treatment. And so I think it's difficult to assign a standard. I think the only time I would seek a second opinion is if there's questions in the pathology. Sometimes those marginal zone cells under the microscope can look confusing and similar to either another type of lymphoma, mantle lymphoma, and sometimes Waldenstrom's. It sounds like we should be able to very clearly identify those cells, but sometimes the pathology can be confusing. And so that's when I might want a second pathology opinion, but I'm not so sure it would be necessary to seek a second treatment opinion. While there isn't, true set standards, there would be common standards that we would use across Canada. Dr. Skrabek and Jerry, do you have anything to add?
No, I think that when there isn't a clear, second treatment or third treatment, there usually is a small list of options, and generally, the option that's best for the patient related to other health conditions, etc., is chosen.
Okay, and the last question for tonight is, how can patients learn more on how to participate in clinical trials?
That's an excellent question. So I think that I think that finding out about open clinical trials for your specific lymphoma subtype, is the first step locally. But sometimes, patients also want to know about open trials elsewhere, I think that your physician should be aware of these. And often also most of the cancer centers will have sort of like a link that can take you as well to explore options.
Yeah, I think it's a great question. Completely agree. The first point of contact would be to ask your hematologist oncologist. They should be aware of trials that are happening, not just at their center, but elsewhere. But then even exploring online, there's many organizations that list different trials in Canada. I believe Lymphoma Canada, Gurjot, you could correct us, but I believe Lymphoma Canada has a link. There's Leukemia Lymphoma Society of Canada. There's CLL Canada. They have a list to ways to look for trials. And even the Cancer Society, Canadian Cancer Society also has, I think, avenues for that. So there's a lot out there. I think looking online is a great way, and speaking with your physician.
Speaking on that, we definitely do have a webpage that talks about clinical trials and connecting patients with that. So to conclude this Q&A session, I would like to thank our experts, Dr. Skrivek, Dr. Gary, and Dr. Stacku for taking the time to participate in today's conference sessions. We hope those watching today learned something new about their subtype. And I would like to direct everyone's attention to attend the closing remarks. Thank you.